Welcome to lecture for Psych 310. Be talking about substance use disorders. To start off, just take a brief look at all different classes of substances with which you can be diagnosed with a substance use disorder. In the DSM, it includes alcohol, you know what that is, amphetamines, it's like speed, caffeine. Most of us are pretty familiar with that. Cannabis is the active ingredient in marijuana. Cocaine is a stimulant. Hallucinogens includes a wide range of drugs, including mushrooms, inhalants. These are those things, huffers, paint, gasoline. Nicotine is obviously in cigarettes. Opioids, this is your things related to morphine, like heroin. And phenylcyclidine is PCP. And then the sedatives, hypnotics, and anxiolytics are typically drugs that are prescribed by a doctor. Your benzodiazepines, like Xanax, things like that. Okay. So, what exactly can you get diagnosed with in the DSM? Well, you can get diagnosed with substance dependence, right, which is what we think of when we talk about addiction. You cannot be diagnosed with alcohol addiction or even alcoholism. You can be diagnosed with alcohol dependence. Right? It's a different word, and dependence and addiction are related. It's sometimes used interchangeably. But the DSM, the wording is very clear, and it's dependence is the name of the disorder. And then abuse is different than dependence, so you can be diagnosed with abuse, but not yet dependence. And those are the main two classes, really. And then there are other kind of just related disorders that are the substance-induced disorders. Things like intoxication, substance-induced intoxication. So, if you're high, is the only time you would meet criteria for that diagnosis. Not a diagnosis that you see made very often, because most people don't go to their therapist high. But it's there for if people present to the ER and they're stoned out of their mind, they can be diagnosed at that time, and it goes into the record. There are certain withdrawal syndromes for some of the substances, not all of them, that syndrome is a diagnosis in and of itself. And then there are just the generally substance-induced whatever. And this is whenever taking a substance or stopping taking a substance cause some other syndrome, like substance-induced psychosis, right, where you wouldn't have had psychosis if it hadn't been for doing all those mushrooms that you did, or whatever. So where the substance is clearly related to the onset or the exacerbation of your symptoms. And it's substance-induced depression, substance-induced psychosis, whatever the case may be. Okay, let's look at the first substance dependence, which again typically talk about being addiction. You have to have just 3 symptoms. You could have more, so 3 or more symptoms in a 12-month period. And before I kind of go through the symptoms here, note that of the list we talked about, even though caffeine is on there as one of the substances included, it's not included for dependence. You cannot be diagnosed with caffeine dependence. Why can people not be diagnosed with caffeine dependence? Because most of the people that voted for which disorders go in the book drink a lot of coffee, is the honest answer. Even though people develop what seem to be other characteristics of dependence related to the use of caffeine due to political and economic reasons, it's not a diagnosable disorder, which is probably good for me. So, other symptoms. One might be tolerance, right, which we all are familiar with tolerance. It's where you either need more of the drug to get a desired effect. So you gotta start chasing that high, and that whatever 1 line of Coke won't do it for anyone. Now you got to do 2 or 3. So you need more to get the high that you're seeking, or there's a diminished effect with the same amount. So they put this in here. It's the same thing. It's kind of going to the idea that even if you're not chasing that same high, but you're using the same amount and you're getting less high, that's evidence of tolerance, which is both a psychological and a physical phenomenon. So that's one possible symptom. Withdrawal, another big one. Withdrawal can include a syndrome characteristic of the drug used. And we can look at some of those in a bit. So different drugs are associated with different symptoms when you stop using them after heavy use. And some drugs don't have withdrawal syndromes at all. The hallucinogens, generally, they'll really damage your brain when you take them, but there's not a withdrawal syndrome when you stop using them. But the symptoms you get usually depend on the type of drug you're using, because it's obviously biological mechanisms involved. So either you stop using and you develop this syndrome, or you have the same or similar drug is used to relieve or avoid withdrawal symptoms. So if you start to experience withdrawal and then use the drug not to get high, so this is people who drink to keep from getting the tremors. Right? So they're not drinking to get drunk anymore. They're just drinking to manage the withdrawal symptoms. Because you're using the substance to prevent withdrawal, not to get stoned or high or whatever, now that qualifies as under the symptom of withdrawal as well. Use more of the substance or use it longer than intended. That's pretty obvious. You say, okay, I'm just going to drink a 6-pack, and you go through a case of beer a night. That would be using more than you intended. I would say, okay, I'm just going to use recreationally. Just going to smoke a little bit this weekend, and that's it. And then it carries on over into Monday and Tuesday and Wednesday, and you're sneaking out of work. Loss of control of use, which means you feel like you can't quit, you can't control how much you're using, or that you want to stop. You spend lots of time either getting the drug, using the drug, or recovering from the effects of the drug. So, and this is kind of getting at the idea of impairment in a way. It's also getting at the idea of how much importance does this substance take up in your life. Are you this recreational user, or have you developed this dependence where you're willing to give up all this time from your life to the drug? Either, again, trying to get it, going downtown or stealing stuff, whatever, or you spend a lot of time drinking, or you spend a lot of time, hungover or unconscious. Important activities are given up. So these are things like going to work, going to school, picking up your kids from daycare. Again, the idea that things that you would do, that you would want to do, that you feel that you need to do and should do, you aren't doing because of the drug. So therefore you are dependent on the drug. The drug has taken up too much importance in your life. And then you keep using even though it causes or worsens a physical or psychological condition. So again, with alcohol, if you have gout and you keep drinking, which makes your gout worse, that would meet criteria for this. If you have some paranoia, and smoking weed makes you more paranoid, and you know that it makes you more paranoid, but you smoke it anyway, that would be with dependence. Okay, but again, in a 12-month period, you have just 3 of these symptoms. So look, it's a lot of symptoms here. So notice, you don't have to have tolerance or withdrawal, which we typically think of as kind of the key features of substance dependence, right? So, well, if you're dependent, that means you develop intolerance and you can't stop, because if you stop, you develop these withdrawal symptoms. Not to meet criteria for substance dependence. They typically do accompany most of the substances we'll talk about, tolerance and withdrawal, especially over long use. But if you have the other symptoms, then you don't need tolerance or withdrawal, right? Which suggests you don't need a physical addiction. You don't need to be physically dependent on the drug to meet criteria for the psychological disorder, which is substance dependence. Right? If you're giving up stuff in your life and you feel like you can't quit and you're spending all this time and you're not doing what you should be doing, then that's dependence. Even if you don't develop these physical symptoms. A lot of people think, oh well, I don't have the physical symptoms if I run out. I don't want to quit, but I run out of money and I can't use for a week. I don't have withdrawal. Therefore, I'm not addicted. I'm not dependent. Depending on the definition, you may or may not be addicted, but you still might meet criteria for substance dependence because of these other symptoms. And when you're diagnosed with substance dependence, it's usually diagnosis isn't substance dependence. It's amphetamine dependence or alcohol dependence or cocaine dependence. So it's the class of substance and then dependence, or it could be polysubstance dependence, and that's when you meet criteria for the use of more than one substance. And then once you're diagnosed with dependence, you can add these specifiers, which can help when you're using diagnostic labels to communicate, help clarify some of the details of the case. So with or without physiological dependence. So cocaine dependence with physiological dependence, or cocaine dependence without physiological dependence. Again, that's that question we just talked about. Are tolerance or withdrawal present? If either one of them is present, then that's evidence of a physiological dependence. If both are absent, then there's not a physiological dependence. It's just a psychological dependence. When I say just, I don't mean to make light, because psychological dependence can be very damaging and tragically for people. But it's different scientifically and clinically than physiological dependence. And that's why it specifies it. And then you can specify the course. So where are they at in their dependence? With the idea that you might get better. You might get worse after having gotten better. So we need to say, okay, where are you in your getting better or getting worse? So it could be you have early partial remission. So this is when you've had at least a month, right? When you had a week of being sober, that's not remission yet. It's just a week. Once you've had a month of being sober, okay, now we're talking about maybe you're in partial remission. So for at least a month, you meet maybe one criteria for dependence, but not three. So one or two criteria are still there, but no more than that. So you no longer meet full criteria, but you meet some of the criteria. And that's partial remission. And it's early if it's between 1 and 12 months. Once you can make it 12 months that far, it's sustained partial remission. But for after 1 month and for the whole year, it's early partial remission. Like I said, if you sustain that partial remission for a year, now it's sustained partial remission. And then after 12 months of no criteria, you have sustained full remission. With the idea being that people that can not meet any criteria for a year are I don't want to say recovered, but they're less likely to relapse than people within that 12-month time frame. And that's why the specifier sets that benchmark there. Although it is somewhat arbitrary, and the research says that, well, it's not that simple. There's a lot of factors that that you have to look at to kind of get an idea of how long sober is associated with kind of a safety zone for somebody. When can they feel safe? It's not as simple as, 12 months clean and you're good to go. But that's kind of what they thought when they wrote these criteria. Okay, so that's substance dependence. Substance abuse is a different diagnosis. Substance abuse is a maladaptive pattern of use leading to impairment or distress, as shown by one symptom, just one, in a 12-month period. So what's a maladaptive pattern of use? Well, as we'll look at the symptoms, you'll get an idea of some characteristics of the maladaptive pattern, but it's use that's more than once, right? It can't be a pattern. One thing isn't a pattern. It has to be a couple of times to be a pattern. And maladaptive, it's use that's not functioning. It's not working for you. If you're Mark McGuire using steroids, arguably that's an adaptive pattern of use. It wouldn't necessarily meet criteria for substance abuse, even though he's abusing a substance. Ironic. Huh? Okay, so the symptoms. Impairment of stress as shown by either failure to fulfill major role obligations. So what's a major role obligation? Well, if you're playing Romeo and Juliet, that's a major role, and you're obligated to play it. But we're not usually talking about that, right? We're talking about your major roles in life. And if you're a parent, that's a major role obligation. If you're a student taking classes, that's a major role. If you're employed somewhere, your job is a major role obligation. So whatever people expect you to do, the role you play, that's important. So not expect to take out the trash, that's a minor role obligation. But your major role obligations, things that if you don't do, there's going to be problems, that's a major role obligation. So if you're not doing that and it's related to your substance use, that meets criteria for substance abuse. Or use in situations where it is dangerous to use. Okay? So this is your drinking and driving, okay? or smoking and driving, or driving a boat, or anything usually involving heavy machinery or transportation. That meets criteria for abuse. Substance-related legal problems. So if you get popped for possession, you now meet criteria for substance abuse. If you get away with it, if you don't get arrested, it's not abuse. Yeah, that's it. Continued use despite social or interpersonal problems associated with the use, which is a fairly fancy way of saying the people who care about you don't want you to use, and you're fighting about it. And so you're still drinking, you're still smoking, you're still snorting, whatever, even though your romantic partner, your family, your friends, fight with you about it. It's causing interpersonal problems or problems in your social world. And even though you know that those problems would stop, the arguments would stop if you stopped using, you keep using anyway. So you're abusing. That's more evidence of a maladaptive pattern of use. So fairly easy to meet criteria for substance abuse. Right? Except criteria are not met for dependence, for whatever substance we're talking about. So this is the idea that it's assumed that everybody who meets criteria for dependence would meet criteria for abuse. So you don't dual diagnose. It's a waste of communicative energy. Right? If you meet dependence, then we don't say, oh, you have alcohol dependence and alcohol abuse. Well, of course you're abusing alcohol. You're dependent. Right? You can't stop using. You're spending inordinate amounts of time drinking. Of course you have this maladaptive pattern of impairments. So you don't diagnose with both. But you can have dependence with one substance and abuse with another. Right? So you could have cocaine dependence and alcohol abuse. So you have cocaine dependence where you have developed tolerance for cocaine, using more and more of it. You develop withdrawal symptoms if you don't use enough, and you can't quit. Right? So you meet cocaine dependence. And then when you're not snorting coke, you drink, but you don't have any physiological dependence with drinking. Usually you plan on having a 6-pack, and that's what you have. It doesn't take you much time to get the beer. Doesn't really get in the way of other things. So you're not dependent on alcohol, but you've got some DUIs, and you usually use it to come down from the high of cocaine when you're ready to come back, right? To ease the crash, as it were. So you're using it maladaptively. So you could have cocaine dependence and alcohol abuse. So we talked before that with dependence you can't have caffeine dependence. Yeah. And you also cannot be diagnosed with caffeine abuse or nicotine abuse. Hey, that's nice. Even though you can be dependent on nicotine, and again we said usually we don't dual diagnose because dependence assumes abuse, but not so for nicotine. Can't be abused. Right? So smoking by a gas station at the gas station, even though that seems dangerous and stupid, wouldn't be substance abuse. Why is nicotine abuse not diagnosed from the DSM? Probably a lot of smokers on the committee that voted, and the cigarette lobby. So, dependence and abuse are the two main categories. And again, you're diagnosed with the substance, the class of substances we're talking about. So, inhalant abuse, inhalant dependence, opioid abuse, opioid dependence. But again, generally, if you're diagnosed with dependence, you don't also get diagnosed with abuse for that same substance. Other things you can be diagnosed with: substance intoxication. Again, so this is those times when you come into the hospital, ER, the police station. Then you could meet criteria for substance intoxication. Hopefully not when you come into my office, but sometimes. Development of a reversible substance-specific syndrome due to the substance, which is a bit redundant, but so the syndrome, a collection of behaviors, cognitions, and feelings that is specific to the syndrome. So most people that use cocaine have these things, right? Like increased heart rate. Most people that use alcohol have these things where they have they can't walk straight, altered gait, changes in depth perception. But a syndrome that's specific to that substance, and it's not permanent. Right? So you're high. It's not Korsakoff syndrome where you've drunken yourself into this irreversible pattern. You'll stop being that way once your body has processed the chemicals that are causing those neurological symptoms. So it's reversible. It's specific to the substance, and then there are maladaptive behavioral or psychological changes due to the effect of the substance on the central nervous system that develop during or shortly after use. So again, stumbling around, blurred vision, dry mouth, increased heart rate, all things that are because the substance acts on the central nervous system, which then sends its messengers out to the other parts of your body, making you do all the silly things you do when you are intoxicated. And of course, our rule-out criteria: the symptoms are not due to a general medical condition or other mental disorder. And there certainly some intoxication syndromes for certain substances look very much like other disorders. Right? If somebody is high on hallucinogens, it can look very much like they're having a psychotic episode, that they're hallucinating. But in fact, they're not hallucinating in terms of, it's not a schizophrenic episode, it's substance intoxication, it's hallucinogen intoxication. And that's another reason why the diagnosis is in here, to help differentiate between those experiences and experiences that aren't directly related to the ingestion of the substance. An example of an intoxication, alcohol intoxication. So, like I said, there are behavioral or psychological changes. For alcohol, it includes inappropriate sexual or aggressive behavior, as opposed to appropriate sexual aggressive behavior, I guess, which again is thought to be due to the effects of alcohol on the inhibition centers of the brain, where you have decreased inhibition, so decreased ability to inhibit your impulses. Mood lability, which is a fancy way of saying your mood swings one way and then the other. So that's the person that's, oh, I'm so happy, I love you, and then is crying the next minute, and then laughing the next. So rapid mood changes. The mood is labile, it's easily changed. Impaired judgment. This is one that's caused people to make some unfortunate choices. The most dangerous, which obviously would be getting behind the wheel of a vehicle, because that probably going to hurt somebody else. But a variety of other poor choices also made when intoxicated, like jumping into a pool of water that's only 4 feet deep head first. Not that I did that before, but it could happen to anybody. Impaired social or occupational functioning. So you can't do your job and you act like an ass. That would be characteristic of alcohol intoxication. And then one or more central nervous system related symptoms, which include slurred speech, incoordination, so clumsy, unsteady gait, so walking funny, nystagmus, which is persistent, rapid, involuntary, and oscillatory movement of the eyeball, usually from side to side, which is always interesting to watch in drunk people. Impairments in attention or memory, and then getting a bit more serious, potentially stupor or coma, if we're moving towards kind of the area of alcohol poisoning. Okay, so you can also be diagnosed with withdrawal for some substances. And I guess I should back up a second and say that because we've often said, we can't be diagnosed with this, that, or the other for caffeine, you can be diagnosed with caffeine intoxication. So when you drink a lot of caffeine and you get really jittery, you may meet criteria for caffeine intoxication. Okay, on to withdrawal. Development of a substance-specific syndrome due to cessation or reduction of heavy or prolonged use. So sometimes you think, okay, withdrawal, that's when you quit. Yeah, it's also if you try to cut back. Right? So somebody who drinks a fifth of Jack every day and says, okay, well, I'm just going to have a couple of shots today. They're still drinking, but they're not drinking as much as they used to when they develop the syndrome, the collection of behaviors that are associated with stopping or reducing the use of alcohol. And again, typically happens only after heavy or prolonged use. But not necessarily heavy and prolonged. Obviously, that would be true, but it could be either one. So heavy use for a short period of time, or light to moderate use for a long time, and definitely heavy prolonged use. And then the syndrome causes distress or impairment, and it's not due to a general medical condition or another mental disorder. Okay, example, looking at alcohol again. 2 or more of the following within several hours to a few days after cessation or reduction of alcohol use. Autonomic hyperactivity, so this is racing pulse, so your autonomic nervous system kind of going nuts. Which, if you think about the thing about these withdrawal symptoms is usually it's the opposite. What happens to your body is the opposite of what the drug does to you, right? So, if alcohol is a barbiturate that slows down your pulse, and kind of slows things down, and you take it away, you get this kind of rebound effect where your body is expecting to get this retarding chemical and doesn't get that retarding chemical. Now your body's, again, the body's all about homeostasis, so it's geared itself up and it's ready to be slowed down, and you're not putting on the brakes anymore. So now it's going nuts. Increased hand tremor. Insomnia, where you can't sleep, nausea and vomiting, transient visual, tactile, or auditory hallucinations or illusions. And this is something that's more commonly seen with really heavy drinkers. You gotta do some serious drinking and then stop to get these. But it does happen to people usually that suffer from alcohol dependence for a long period of time. And if you hear about DTs, delirium tremens, this is when you have those frightening hallucinations and tremors together. You also may experience anxiety. Again, think about people are using alcohol to treat their anxiety because they're anxious about something else. take that away, the anxiety is going to come roaring back, stronger than before. And then potentially grand mal seizures, because you've been screwing with your brain for a while, and now your brain is out of whack. Substances that are notable for not having withdrawal syndromes that are diagnosable include marijuana and LSD. You cannot be diagnosed with withdrawal for either one of those because there aren't specific withdrawal patterns of withdrawal that we've seen. I suspect that might change with marijuana in the future as research grows. Because the reason it's not here now is because few people experience a physiological dependence on marijuana. But just from clinical experience, many people that I've worked with, especially those that use marijuana to self-medicate for anxiety disorders, there is a price to be paid for withdrawal. Okay. Now, I mentioned the substance-induced disorders. It's a fairly long list. So substance-induced delirium, right, which is delirium is a cognitive disorder, where as the name as it's entered our popular culture, our popular vernacular implies, where you're delirious, you have a disruption in cognitive function, you don't know where you are. You can have substance-induced persisting dementia, which is a bit more serious, because delirium, usually you get better. Substance-induced persisting dementia, this is when you've caused some permanent brain damage, things like Korsakoff's syndrome, because you've killed your liver and caused various other things to happen. It takes a while for that to happen, unfortunately. Persisting amnestic disorder, again, brain damage. Substance-induced psychotic disorder, substance-induced mood disorder, which could be depression or bipolar. Substance-induced anxiety disorder, sexual dysfunction, or also pretty commonly, substance-induced sleep disorder. Alcohol tends to wreak havoc with the mechanisms we use to go to sleep. So, to get diagnosed with one of these substance-induced disorders, the symptoms of the mental disorder, there are symptoms of the mental disorder during intoxication or withdrawal that are exceptional. So that means that they're in excess of what you would usually see in withdrawal. For example, with alcohol withdrawal, you may see some hallucinations, but if they have really well-developed hallucinations and delusions, now we're thinking, okay, this isn't just withdrawal. They've gone into a full psychotic episode, and this is substance-induced psychotic disorder, not just alcohol withdrawal. Otherwise, it would just be alcohol withdrawal. So that's for the substance-induced disorders. So sometimes you have these, the symptoms are beyond what you would expect during withdrawal or intoxication. Well, it could be that it's viewed clinically that the substance is the cause, is the origin of the mental disorder. Usually this is determined in terms of the temporal relation of the onset or offset of use. So the rule of thumb is, do the symptoms persist more than 4 weeks after stopping the drug? If so, then it's not substance-induced. It's just you have whatever that disorder is, and maybe substance dependence. So if your psychotic symptoms stop a month after you have stopped using alcohol, it's thought not to be substance-induced psychosis, but if they persist. So if after a month of stopping alcohol, you still have the psychotic symptoms, it's not substance-induced psychosis. You have probably schizophrenia and alcohol dependence. So depending whenever the symptoms start and stop, and again, usually for substance-induced, the symptoms weren't there until you started using, or until you went into withdrawal, if it's intoxication or withdrawal. But if they are there for a long time after withdrawal, or if they're If they're there well before you started using, then it's not substance use. It's just that disorder and probably a substance problem. The other thing would be the typicality of symptoms. Can be a clue. If somebody has their first manic episode at 45 years of age, and that happens after using cocaine, that sounds more like a substance-induced mood disorder. Or if somebody's using methamphetamines and they have some paranoid delusions, that's typical. So we don't think of that being methamphetamine-induced paranoid schizophrenia. I said, well, that's paranoia that comes with methamphetamine use. If you're using methamphetamines and it's associated with an onset of depression, well, that's strange. Now that might be a substance use disorder. Some weird way your meth use may have caused depression, which would be rare. So notice that for the substance-induced disorders, generally, for it to be substance-induced, it has to be kind of short-term. So during intoxication or during withdrawal, but more than just intoxication, more than just withdrawal. With the only exceptions being the persisting dementia, persisting amnestic disorder. That may change eventually. There's debate and ongoing research to look at whether or not substance-induced psychosis may be something kind of a persisting psychosis, where we no longer think, okay, well, you have a substance problem and schizophrenia, but actually the schizophrenia or the psychosis is caused by substance. In particular, marijuana is one candidate. And the debate is whether or not the marijuana use causes the psychosis, or whether or not it just happens to reveal the psychosis. That the person, if they had used marijuana, would have shown up as having schizophrenia sooner or later, but the marijuana use just hastened the discovery of their symptoms. So something to be looked at in the future. Okay, what do we know about substance disorders, epidemiology, kind of statistics about use? One, we know that use doesn't always lead to dependence. So the whole idea that, well, if you try this once, you're going to get hooked. Not always. Sometimes. Some people will use cocaine one time and they'll be hooked from that first use. Other people, they'll use cocaine one time and they'll go, well, that was okay, or oh shit, that sucked, I'm never doing that again. And a lot of it really depends on your physiological response to that first use. And then there's also obviously other things involved in terms of societal expectations, social pressures to use more or to not use, and the reasons you're looking for using a mind-altering substance. But some substances seem to be more likely to lead to dependence than others. In terms of if you use it once, what percentage of people are likely to develop dependence? What would you think would be the most likely substance to lead to dependence? In some ways, the most addictive substance. We talked about alcohol, amphetamines, caffeine, cannabis, cocaine, hallucinogens, inhalants, nicotine, opioids, phencyclidine, sedatives. What's the most addictive? Most people go with the opioids. Most people go with heroin. And it comes in second. Oh, well, cocaine. Cocaine's very addictive. Talk about that crack. No, coke makes it into third place. First place, good old nicotine, the cash crop of the Americas. So 24% of people who use nicotine will go on to develop dependence. So kind of very highly addictive potential. Probably not statistically different than the percentage for heroin, 23%. So about equally as addictive as heroin. And then cocaine up to 70%, and then alcohol below that. Okay. So the first time you use, and then when you develop dependence, it takes about 2 to 3 years. And obviously, to meet criteria, there would have to be at least 1 year right? Because that's the diagnostic criteria. Is it has to be 12 months of experiencing those three symptoms. But the average time isn't 1 year. If you kind of expected, oh, people use and then they get hooked and they spiral out of control, it doesn't seem to be the way. It seems to be that people use, and they may use socially, they may just be experimenting, and then maybe they'll come back to it later. But within 3 years, for those people that do develop dependence, because it's not everybody, but for people who develop dependence, within 3 years, they've met 4 criteria. Looking at gender differences in abuse, in terms of alcohol abuse, at least, the rates are similar until about age 17, kind of boys and girls, teenage, young men, young women. Then after that, much higher rates in men than women, which some people speculate is due to hormonal influences, although your hormones are surging well before 17 for most people. But interestingly, we see this big difference in alcohol abuse and dependence between men and women. And we see a similar difference between men and women in diagnoses of depression. But the other way, where more women being diagnosed with depression. Some people have argued that it's the same phenomenon manifesting differently, that men who would have been diagnosed with depression are self-medicating. They're treating their emotional pain, their numbness, their sadness, their irritability, however they're experiencing their depression, with alcohol. And because of their heavy alcohol use, they don't develop the symptoms of depression. One thing. How prevalent is dependence? So again, do you think this would be related to the addictive potential we saw before? In some ways it is, with again, tobacco there at the top. So it's one of the most addictive, and so it's the one that most people are diagnosed with dependence. But then alcohol is next, and then cannabis, cocaine, amphetamines on down the line. A lot of people go, gee, well, where's heroin? Shouldn't heroin be up there? Aren't a lot of people diagnosed with that? No. Why aren't more people diagnosed with heroin dependence? Well, a couple reasons. It's harder to obtain than some of these other drugs, particularly tobacco, alcohol, and cannabis. Much harder to obtain heroin than those other three. And the other thing is, you don't live very long being dependent on heroin. So if you don't live very long, you can't ever get diagnosed with it. So that's the reason why the numbers are lower than some of the other substances in terms of how many people are dependent on it. So it's highly addictive, but it kills you quick enough that you won't have to worry about getting diagnosed. So yeah, good for you. And some people kind of wonder, well, gee, cannabis seems kind of high up there. More people are diagnosed with cannabis dependence than cocaine or amphetamines. Why is that? Well, again, it has to do with availability and number of users. A lot more people experiment with and socially try to use cannabis than do those with cocaine or amphetamines. And that's why, even though cocaine might be more addictive, more people become dependent on cannabis just because a greater number of people are using it. So, some people say, oh, well, it's not really a problem. Yeah, there's more people dependent on cannabis than there are dependent on cocaine. So, yeah, statistically, in many ways, is a problem. Another thing we know about the statistics, the rates of abuse and dependence decrease after young adulthood. Right? So they climb, and then in kind of your early 20s, and then after that, in society, it decreases. Why do you think that is? Researchers haven't come up with a definitive answer, but you can kind of you could probably hypothesize a couple of reasonable explanations. One, when you become a young adult, you begin to have more responsibilities, right? So, in high school and even college, those folks that go into college right out of high school, many people in America have a fairly sheltered existence, especially your middle class to kind of upper class folks, fairly sheltered, where they don't have much to worry about, and they can experiment with drugs and abuse drugs without too many untoward negative consequences. Right? If they're smoking a lot of pot on their college dormitory, not as likely to get arrested for that than if they were in some other setting. So they're fairly protected. They only have to go to class 3 days a week. You know, if they get their classes set up to where they can sleep in till noon, get up, go to class at 1, be done at 5, party again at night, do it all over again. But then once you become a young adult, things change, right? You get a 9-to-5 job, or you get a family, and you have more responsibilities, and so the cost of abusing and using these substances becomes greater, and you can't maintain that lifestyle, the lifestyle that society expects of you, and the lifestyle that the substance would demand of you. That's maybe one reason. Another reason is people die. Right? People that abuse and are dependent on substances, they don't live a long time. So if they're drinking and driving, and then we all read about this every year. At the end of the school year, teenagers in the paper killed in drunk driving accidents, right? So they don't live to be older. So their numbers, they won't be a 40-year-old alcoholic because they're dead. That's another reason why the numbers may decrease after young adulthood. What else do we know about disorders? We know that they have a high level of comorbidity with a variety of other disorders, and this can be for many reasons. One, people frequently use substances to treat their symptoms, right? And usually not well. Most people aren't good pharmacists. They don't know the right amount to use. They don't know the right drug to use. The people that use alcohol to treat depression, that's really going the wrong way. It's not going to make your depression worse. It's not going to make your depression better. It will actually make it worse. You will depress your mood, and you will create more interpersonal problems that will further exacerbate your depression. But people try to treat their symptoms of depression, anxiety, even, you may notice if you ever are in a psych ward, it seems like everybody who has schizophrenia smokes. Geez, why is everybody smoking? Well, it seems that nicotine activates some of the muscarinic receptors in the brain that actually affects some of the symptoms of schizophrenia and helps manage some of the symptoms of schizophrenia. So in some ways, some of them are actually self-medicating, somewhat effective. It's not a cure, but it does have an impact on symptoms. So one of the reasons for comorbidity is self-treatment. Another reason would be that the drugs can cause symptoms. Right? And in a variety of ways, both in kind of that substance-induced way, and then also in terms of the drugs leading to certain experiences which put you at greater risk for disorders, right? Obviously, dependence is often associated with social interpersonal problems, and as your social interpersonal world gets smaller and all your friends become junkies who are only interested in you to the degree that you can help them get high, that's likely going to lead to increased experiences of depression, right? Because we need healthy interpersonal relationships to have a healthy mood. Also, if you are dependent on a substance, frequently, if you're not independently wealthy, you don't have a trust fund, you have to either do some illegal things, or in addition to obviously buying illicit drugs, you may have to rob or engage in other criminal activities to obtain the money sufficient to support your habit. You also have to buy drugs from people who are, by the nature of selling drugs, criminals, and sometimes violent criminals, which puts you at risk for victimization. I remember a client once who substantial anxiety, smoked a lot of marijuana, and she kept getting robbed, and she couldn't figure out why. Well, all your friends are drug dealers. That's why you keep getting robbed. So again, the drug use associated with a culture that's associated with increased risk for disorders. Okay. So what causes people to abuse and become dependent on substances? Well, different things for different people. It also differs somewhat by type of drug, though there are certainly some commonalities. We'll look at alcohol as one kind of exemplar to talk about some of the etiological factors. We know that social factors play a role. At a very broad level, culture is important. Cultural attitudes toward drinking and drunkenness play a role, and the likelihood that someone will abuse alcohol. For example, people who are Muslim don't drink. It's prohibited. And then Jewish people, and among people who are not just cultural Jews but also religious Jews, there's a disdain for intoxication, not for drinking, but for being drunk. It's kind of culturally frowned upon. And so, not surprisingly, there are lower rates of alcohol abuse and dependence in those groups. Parenting matters. Obviously, one way that parents can influence the use of a substance, in particular alcohol, would be modeling. Parents that model abuse, not necessarily use, but model abuse of alcohol, more likely to have kids that also abuse alcohol. Their attitudes toward drinking matter. So does providing access to alcohol. You know, if you don't drink, you have no alcohol in your house, then it's harder for your kids to get alcohol. Not that it's impossible; they can go to their friend's house, you know, probably, but it's harder. If you have the alcohol there in an unlocked liquor cabinet, it's pretty dang easy to get it and fill it with water and food coloring after they're done. But the biggest kind of parental contributor to risk factors for dependence is level of parental monitoring. So the degree to which parents monitor, the degree to which they pay attention to where their kids are. Parents who keep track of where their kids are and know who they're hanging out with, those kids are less likely to develop substance abuse and dependence problems than parents who, oh, I don't know where they are. They've been gone 6 hours, but they're always back by curfew at 11, so I don't worry. That's low parental monitoring, and that's a parental choice, but one that is associated with higher risk for alcohol use and dependence in kids. So we know that alcoholic parents are likely to have kids that use alcohol. So not necessarily abuse, but the children of parents who have alcohol dependence are more likely to use alcohol than children of parents who aren't alcoholics. And for the reasons we probably just talked about. You know, I think, oh, well, if your parents are alcoholic, then you forswear alcohol and never drink. And that may be true for some people, but statistically speaking, doesn't seem to be the case. It seems that kids with parents who are alcoholics tend to drink, whether or not they abuse differently. More important than parenting, though, in terms of, at least in terms of the parental attitudes toward drinking, or parental monitoring, important, but whether or not the parents drink, less important, statistically speaking, less important, less influential than whether or not a child's peers or siblings drinks. So the degree to which peers and siblings use alcohol is a better predictor of whether or not an individual child will use alcohol than if their parents use. Which makes some intuitive sense, right? Because, and there's a whole other body of research that talks about how once kids get up into adolescence, that the peer group becomes much more influential than the parents in terms of many, many behaviors, including risky behaviors, including alcohol use, nicotine use, sex, all those things. If you want to know what a kid's going to do, statistically speaking, find out what their peers are doing, instead of asking their parents what they think is right and what they've taught their child to do. Not that doesn't play a role, but it's not as good a predictor as what their friends are doing. Okay, I won't get into that. So the social factors are important. There are also biological factors. One of which is, again, I talked about before, that initial physiological reaction. Either a pleasant reaction to a substance, you're more likely to use it again. So in terms of alcohol, about half, 30 to 50% of people with Asian ancestry will react to alcohol with flushed skin, nausea, and abnormal heart rate. So alcoholism is much lower in people of Asian descent than other people, probably because that initial physical reaction is fairly averse. Right? They lack a certain enzyme that break down the alcohol the same way other people do. So they have less problems with alcohol abuse. Little story related to that. Whenever I was, I must have been 7 or 8, I asked my mom. I said, "Mom, I think it's time for me to have a beer," because my family, a lot of drinkers. And my mom, a smart woman, said, "Okay, I'll get you one." And she went to the garage and got a Pearl Light, 68 calories, not out of the fridge, hot, out in the hot garage. Poured it in a plastic cup, gave it to me, and I happily accepted. "Thank you so much for this beer." And that was the worst thing I'd ever tasted, a hot Pearl Light in a plastic cup. I didn't drink again until I was 19? Yeah, 19 years old. So, that first physiological experience is important. If you have a good experience, more likely to use again, the more likely to use again, the more likely to develop abuse and dependence. If it's a bad experience, less likely to use or abuse. Genetics, like everything else, play a big role. That's one of the reasons that parenting is important. If you're the biological parents of a child, it would give your kids your genes. And genetics are associated both with the level of social drinking. So the level of social drinking, how many drinks a parent has, socially a week, is correlated with how much their child will drink as an adult, if they're biologically related. It's all the degree to which a parent has alcohol dependence is also related to the likelihood of their child developing dependence if they're biologically related. We know that largely again from twin studies, adoption studies. And for a long time, they thought they would find the alcoholism gene. But this is back in the naive days of molecular genetics, when I thought a gene controlled complex things. But now we realize there's not a gene for alcoholism. It's a combination of genes. A combination of genes that probably influence the metabolism of alcohol. Right? So the rate at which you metabolize alcohol is related to how much you can drink before you experience the negative effects. So that's going to influence you. Genetic influences that relate to sensation seeking. So you're wanting to seek out different experiences and take risks, and also those associated with decreased inhibition. So, because many Western societies say don't drink or don't drink and drive, at least people who are less inhibited more likely to violate those prohibitions. And so genetic factors that influence those traits may also play into this association, genetic association with alcohol abuse. In terms of neuroanatomy and neurochemistry, the way the brain works and is shaped, we know that most drugs affect reward pathways in the brain. The mesolimbic dopamine pathway seems to play a role with alcohol abuse. And some people that suffer from alcohol dependence, there's an exaggerated activation of the endogenous opioid system. So they get a better buzz than other people. Another thing we know is that alcohol increases serotonin in the short term, which we typically associate increases serotonin with increases in mood. Right? So with some short-term increases in mood in people that maybe are in more need of a mood lift. I'll be at greater risk for dependence because of how it works on the brain. In terms of psychological factors, expectancy effects are important. Placebo studies, placebo studies have found that that behavior is influenced by what people expect to happen. Right? So people with initially more positive expectancies of the effects of alcohol will use it more often. So if we tell you, okay, there's this alcohol and you're gonna feel so good, you're gonna be loose, and you're gonna have a good time, you're gonna use more of it than somebody else who will say, okay, there's some alcohol, you're gonna drink it, and it'll probably make you a little queasy, a little nauseous, but you get a little buzz. Both people, you can have one drink, and I'm gonna leave the bottle here. So they both have one drink. They're gonna have whatever reaction they have, but one of them, because of their expectancy, will experience, to some degree, more of those positive effects than the other one. So what we expect to happen as a result of our use influences how much we're going to use. I think alcohol is gross, it's going to make me feel sick. I'll try it, and you try it, and you go, oh yeah, I kind of feel sick. Right? But if you don't expect that, you expect good things, then you'll feel more good things. Expectancy is very powerful. There's also the tension reduction hypothesis, which is basically that you drink to feel different. Usually wanting to feel less anxious. But sometimes people use it just to feel less of whatever it is they're feeling. There could be pain, could be anger, not necessarily anxiety, but this idea that, well, if I drink, I won't feel these painful emotions or these uncomfortable emotions as much. I'll be numb to it, or I'll feel a little better because these bad feelings will go away. So it's not so much about drinking to feel good, but drinking to feel less bad. There's people that have a lot of negative affect and a lot of this built-up tension, greater risk for dependence and abuse. And another theory is one of attention allocation. Because we know that alcohol interferes with capacity for controlled and effortful cognitive activities. You can't think straight. Right? So, because of this, this might explain why drinking makes some people happy and others sad. Right? So the idea being that when you drink, you can no longer focus your attention. You can't effortfully shift it from one thing to another. But I'm drinking to forget. And that may or may not work. Depends on where you're drinking. So if you're, your partner just broke up with you, and you drink at home, surrounded by pictures of them, you're going to feel much, much worse, because you won't be able to shift your attention away from them. You're reminded by everything in the environment of them. You'll feel nothing, think nothing of nothing but them, and feel worse. If you go to a bar, maybe that you never went to with your partner, and get drunk, and there's lots of other people there doing fun things, then you might successfully distract yourself from your misery, because you won't be able to shift your attention from the bright lights and loud noises around you. So the environment you drink in will influence the effect it has on you, because of your inability to shift your attention. And then we also know that not only can you not shift your attention, but you can't think as coherently. So if you've been ruminating on something, so if you've been thinking about one thing over and over and over again, once you get drunk, it's hard to think about that thing over and over again. You can't, because you can't think straight. And to some people, that is rewarding. They get a break from their rumination, a break from all the worry. So, how do we treat substance-dependent substance abuse? Again, we'll stay focused with just one substance, with alcohol, to kind of be consistent here. Well, the first question to ask is, well, what's the goal? Is the goal abstinence, where you're no longer using at all? Or is it controlled use? And this is a significant debate in the research and in the clinical world, whether or not one goal is better or more realistic than the other. What seems to be the case is it depends. It depends on the individual. For some individuals, abstinence is the only appropriate goal, and they will never, ever be able to be controlled users. And that's kind of the 12-step program. Once an alcoholic, always an alcoholic. If you have one drink, you're going to backslide and be back to being where you were. And some people seem to be like that, where they can't ever, once they stop, they can't ever use again, or they relapse. And they can't use socially. Other people don't seem to be that way. Some people seem to, after developing a profound pattern of dependence on a substance, after getting sober and not using, and no longer having physiological dependence, at some point in time they can go back to drinking or smoking or even snorting socially. And it seems to be this weird individual thing. It's probably related to their own a combination of factors. Chief among which I would argue would be probably physical factors. So which is the appropriate goal? Depends on the individual. In terms of what you have to do, frequently, if you're a heavy user of certain substances, before anything else can happen, you have to go through detox, right? So a detoxification is when you're monitored by medical professionals while going through withdrawals to make sure you don't die. Right? So this is for heavy users of certain substances, like alcohol. You go through detox first, so that you don't have a seizure and die before you can learn to stop drinking. And then after that, there's a variety of things that might be used alone or in combination. There are certain medications. This is America, we do love our pills. Things like disulfiram, naltrexone, camprosate. Disulfiram is something that makes you sick if you drink. So you take this pill knowing that, okay, when I take this pill, if I drink later, I'll get really sick. So if you don't want to drink, don't take the pill. And that's what people do. So not that successful for a lot of people. Naltrexone is a little different. Instead of making you sick, it just reduces the rewarding effects of alcohol, so you don't get as much of the good stuff that you get with drinking, the lifts the mood and whatnot. And this works a little better than disulfiram, especially if combined with therapy. And then the last one, I can't say, they're not exactly sure how it works, except that it seems to make withdrawal less bad. So it makes withdrawal more tolerable, and so you're less likely to be tempted to go back to using to deal with the withdrawal symptoms, which again is similar in effectiveness to naltrexone when used with therapy. Also, not surprisingly, what drug is also used? SSRIs. If people also have accompanying depression, which is quite often comorbid with alcohol dependence. Kind of large-scale treatments, Alcoholics Anonymous. This is obviously a large group-based program. This is where abstinence is a must, and the belief is that people can't recover on their own. It's this 12-step program, and you're paired with a peer who's further along in the recovery process than you, that's there to help you, and you're expected to go regularly to meetings and talk about your struggles, and the support from the group is there to help you stay clean. So this isn't to get sober. This is after you stopped drinking and you've gone through detox, and you go to something like Alcoholics Anonymous to maintain your sobriety. Does it work? Well, about half the people who attend drop out within 3 months. And are those people recovered? Probably not. We don't know because they drop out. Probably not. So for those people, it probably didn't work, or at least didn't work at that time. Maybe they'll come back. They drop out initially. Of those who stay, so if you make it past 3 months, it does seem to work pretty well. About an 80% recovery rate. There's been a lot of research on why it works when it does work, and nobody's come up with a definitive answer. Whether or not it's the 12 steps in particular and going through them in the order that's involved, or if it's the social network that it provides, and by that not just people supporting you and not drinking, but also increased interpersonal interactions that are positive. Is that part of what's contributing to the recovery for some people? Probably so. Other than those kind of group programs, there's also therapy. Certain therapy skills that are designed to help people who are struggling with dependence. For CBT, usually includes a couple components. One would be coping skills training. So things like anger management, social skills training, and the social skills training. A lot of different things too, but one of the things is teaching people how to resist peer pressure. So the idea being that if a lot of times in the group approach, they tell you have to get rid of all your addict friends because they're going to drag you back down. And sometimes that's possible, sometimes it's not. If they're your family, it can be a bit harder to cut those ties. So we teach people social skills. Okay, whenever you go to a party, and what do you do to keep from being pressured? And one thing I see people is put a cup in your hand. If people see you have a cup in your hand, they're less likely to offer you a beer or whatever. Even if your cup is empty, keep it in your hand and pretend to drink. Teaching skills like that. Training people about the expectations of alcohol, how important that is. Helping people identify what negative emotions might trigger their drinking episodes. So you drink when you feel sad. Okay, now let's back it up. What happens before you felt sad? What were you doing? What were you thinking? And then let's figure out a different way to react to those thoughts and than how you felt, or how to react differently to those feelings than drinking. There's usually a pretty big focus on relapse prevention. Marlatt said that quitting is easy, but staying quit is the hard part. So most people can stop using, especially because whenever they hit rock bottom, as the colloquialism goes, but it's hard to stay sober after your life starts to improve. But from the idea of relapse prevention thing is to look at relapse differently. Don't look at it as all or none, and teach people that you've been sober for 3 months now. That is fantastic, and you're never going to drink again. If you do, because half the people that come to this program drink again. If you drink again, you have not relapsed. Okay? So, because why is it's not relapse? What? Why would you say it's not relapse? Of course it's relapse. You just had a drink. No, it's not relapse. It was a slip. Don't have another drink. Call your sponsor. Call your friend. Call your therapist. Talk about it. And a lot of this is kind of based in many ways on what we know about dieting and restrictive eating. When people are restrictive eaters and they diet and they don't eat, and then they have that one chip, it leads to eating the whole bag. Because there's this thinking that, shit, I had the chip, my diet's ruined, might as well eat the whole bag. And so you want to get rid of that thinking. No, don't. Just because you had that one beer doesn't mean you have to drink the whole case. You're not relapsed yet. That was a slip. You can still stop. Get back on track. So teaching people about that improves recovery. And not that they won't, now they know that I won't have the one beer. No, they might have that one beer, but they won't necessarily. It'll be less likely to drink the whole case after that. Other techniques that you might use, short-term motivational therapy. things like motivational interviewing. A lot of this relies on identifying where they're at in their stage of change, and asking people questions in such a way that they think about what they're getting out of their use. And you're wanting to have them focus on the impact of the use, but not in a confrontational or judgmental way. So like, okay, so you've been drinking a lot, and now your wife left you, your kids don't love you, and you've lost your job. You really think it's a good idea to keep drinking? No, that's not motivational reviewing. The short-term motivational therapy, where you're trying to build the motivation, you're asking them, okay, what's your favorite thing about drinking? Start with the positives. Wow. Okay, and you don't say, oh, that's stupid. Okay. Has drinking ever cost you anything? Is there anybody in your life that doesn't like your drinking? And you get them to talk about it. Well, my wife, da-da-da. Okay, does this cause problems in your life? Yeah. Okay. And you don't follow with, well, then you should quit. They will come to that recognition. Ask them questions to get them to think about the impact of their use on their life. And as the evidence is laid out before them by themselves, you're kind of pointing the question of, is this all worth it? Might you be interested in trying something else? And then you can kind of move them to, from pre-contemplative to contemplative into action, and not all in one session. Usually, it may take multiple times to move somebody if they I don't have a problem. No. Well, then you've got to start baby steps and get them to look at. Huh? I don't know if it's a problem or not. Let's talk about it. In what ways has it affected you positively? In what ways has it affected you negatively? And if the negatives outweigh the positives, do you want to change? You don't tell people you've got to change. You got to ask them, do you want to change? Because it's got to come from them. So what do we know about these different treatments? Well, different treatments work about equally well. You say, well, what's the best treatment? Well, go to treatment. That's the best treatment. They work about equally well, on average. It doesn't mean that one treatment won't work better for you than another one, but we haven't identified yet those individual factors where we say, okay, if you're like this, then you need AA, or if you're like this, you need individual therapy. It'd be great if we figured that out. Not there yet. But on average, all the treatments that have been around for a while work about equally well. What's most important for a good long-term outcome? Again, that's what we're concerned about. We're not concerned about getting you sober now. That's easy. But for long-term, what has to happen? A couple things. They have to have adequate coping resources. Coping resources involves coping skills. It also involves tangible resources. People that have greater access to health care and who have greater wealth to some degree have better outcomes because they're associated with other things. Social support is extremely important for that long-term outcome. Substance dependence is an incredibly difficult problem to struggle with alone, and it is a problem that tends to lead people to be alone, right? Because when they're using and abusing, there's a lot of lying and manipulating that goes on that tends to estrange people, and people give you a second chance and a third chance and a fourth chance, and then they cut ties because they can't take it anymore. So isolation is a frequent consequence of substance abuse, substance dependence. But if people can get that social support somehow, if it's a 12-step program, if their family will take them back, if it's some religious group, whatever, that's important. And then third, a low-stress environment. Because regardless of why you use in the first place, the more stress you undergo, the more likely you are to result to using a substance as a coping mechanism. And we're trying to teach you coping mechanisms, but the other end, we gotta say, okay, well, at the same time, maybe it's not such a good idea for you to be a college football coach, or an air traffic controller, or a first grade teacher. These are all things I imagine being very stressful jobs. Find some place in the world for you that would be less stress, because given your vulnerabilities and your history, you just can't do those things anymore. Okay. So we talked about substances, dependence, abuse, withdrawal, intoxication, substance use disorders. Talked about some of the statistics, different theories about etiology, and then last a bit about treatment. Again, you don't have to know all the different substances, but it is important to know the difference between dependence and abuse and intoxication and withdrawal. And you should be in good shape. That's it for now. Take care.